Hvala, profesor Eržen. Nadaljujem še jaz najprej za eno definicijo. Krhkost opredeljujemo kot sindrom, ki je povezan z visokim tveganjem za neugodne zdravstvene izide in predstavlja, po eni izmed številnih definicij, zdravstveno stanje, ko se zaradi številnih vzrokov in dejavnikov so zmanjšani mišična moč, vzdržljivost, fiziološke funkcije, posledično pa je zvečano tveganje za razvoj oziroma povečevanje nezmožnosti ali celo smrt. Četudi se najpogosteje omenja fizična krhkost, je po mnenju mnogih potrebno upoštevati tudi druge komponente, kot so kognitivno in razpoloženjsko stanje, socialne in ekonomske okoliščine, življenjsko okolje, življenjski stil, multimorbidnost, nezmožnost in motnje čutil. Joint Action Advantage, projekt skupnega ukrepanja Advantage, je prvi razpisani evropski projekt na temo krhkosti. Pri pripravi projekta smo takoj prepoznali priložnosti povezovanja. Tudi v ta namen je danes organizirana ta konferenca. Menimo, da je za implementacijo kakršnekoli sprememb potrebno vključevanje ključnih strokovnih kot tudi odločevalskih ravni. Hkrati našo konferenco v pozitivnem smislu zlorabljamo tudi za osvetlitev pomena urejene geriatrične oskrbe. Tako krhkost kot urejena geriatrična oskrba sodita med cilje resolucije o nacionalnem planu zdravstvenega varstva do leta 2025 skupaj za družbo zdravja. Tako, pričenjamo z prvim vsebinskim predavanjem. Manfred Huber, Coordinator for Healthy Aging, Disability and Long-Term Care from WHO Regional Office for Europe, will present a lecture on policies to prevent frailty in community dwelling older people, a European overview. Please.
Good morning, Madam State Secretary, dear conference organizers, ladies and gentlemen. I'm very grateful for this opportunity today to be with you for this exchange about frailty as a public health concern of emerging importance, and I will present an overview, some snapshots on where member states currently in Europe are, what are some of the lessons and success stories that we are already seeing, and how this can be sharpened, everything brought together under the frailty concept. Now, when we talk about the European region of WHO, I was start with a reminder that it is quite a big region. We have 53 member states, and they are in different stages of the demographic aging process. And what you see here is an overview about the trends from 2000 to 2015. And you see some broad geographical groups. You see we are reaching out far to the east, including some Central and Western Asian countries. And in fact, with the exception of Central and Western Asian countries, you see that in all other regions we have an increase over these 15 years of the share of older people. How do you see this? You see the bubbles are all above the line where the growth rates of the whole population and of the older population would be the same. Now, the size of the bubble is simply the current number of older people. So you see where older people live in Europe. And we have here a basic distinction between those living in predominantly urban regions and those predominantly in rural regions. And you see, of course, the urban regions, Western Europe, Southern Europe, are among the most, and Eastern Europe, very important Eastern Europe. If you see the distance from the quality line is here very big. These are the centers where aging takes place very rapidly. But then we also see that aging is also in the predominantly rural areas, and there, with the exception of Central and Western Asia, you see at the same time we have in most of these at the same time declining populations. So we have population migration between these centers, and when we talk about aging policies and then specifically on how to improve attention to frail older people, people living with frailty, then we see we have different challenges when we talk about different regions and countries, and we are faced with huge differences, varieties of the living situations of older people. Now, we have heard basic definitions already on frailty as a geriatric syndrome, where the focus is on that frailty, first and all, is a state of higher risks of negative health outcomes, but it is very important in formulating policies to be always clear that the health outcomes that may come are not necessarily immediately linked to the frailty definition. Now, for you as health practitioners and researchers, this is all common good, but I think it's very important, and we have to still in many instances go quite a long way to make this clear in policy formulation, that when we talk about frailty, it's not a disease. It can be a symptoms of important underlying or even masked disease, but this is not necessarily the case. It's also not necessarily already a status of disability or even severe disability. And it also should not be seen as, let's say, last stage in life, so meaning what can we really do rather than having very costly care systems. On the positive side, then the main message here from the research is more and more that frailty the onset can be either postponed or maybe even prevented when there are certain events like falls, and the consequences also of frailty can be postponed or maybe even prevented, or in some cases frailty may even as a syndrome in itself be able to be reversed, at least in some cases. So in the literature it has been said frailty in a sense is a transition phase between successful aging and disability. We could maybe even see frailty can be part of successful aging and disability. So living with frailty does not mean that is the end of story of healthy aging. Now, there are various policy measures, and we will talk about these, I think, throughout this whole conference. It is very welcome and promising to see that the joint action is addressing these topics and is adding to the systematic reviews to see what works. Many of the interventions are recent, the reviews in the literature can be recent, so there are still open questions, and it is a big team effort to move this area forward. And I will now show you some examples how quite a number of the policy interventions and strategic areas that have been designed with member states under WHO strategy and action plans address some of the preventive but also the care aspects of frailty, and then a first snapshot on to see how this is reflected in some of the national action plans. Now, you have heard we have since 2015 a first world report on aging that has helped to update and clarify earlier approaches on active and healthy aging that have been quite influential of WHO, and that has led to the adoption of a global strategy and action plan, which has relatively ambitious goals, and I will say a bit more about that, but broadly it is in line with, as I will later show, with an earlier European strategy and action plan. Now, the World Report has updated and renewed a public health framework on healthy aging that many of you, I'm sure, have seen, which is a life course perspective that clearly distinguishes between functional ability, what we want to enable people to be able to do, to fulfill in their lives, even on highest ages, versus what might be declining health capacities, health also including mental capacities, which is here called the intrinsic capacity. And the gap here is a positive gap between the two lines, because it shows how you can lift up from stronger declines of intrinsic capacity to less decline of actually what people are left with, what they can do in their life. And then you see over the life course, basically healthy aging starts with birth or even preconception health. And there's actually evidence in the literature on very early links of very early interventions with outcomes in high age. And what the global strategy and action plan actually does is that we have two blocks separately: health services and long-term care, including with strategies on better integrating care across them. But what is, I think, a quite important emphasis here is that with this action plan, more than 190 countries committed to build up systematic long-term care systems. Certainly this is also one of the fields of work which we see is most active of member states that work with the WHO regional office. Now, we have also heard already some of the key concepts here of the public health framework for WHO, which is healthy aging, the preservance of functional ability, in a broad sense, so including well-being in multidimensional perspective, where functional ability is what enables people to be and do what they have reason to value. So it's very much a positive view to not see automatically older people or people with health problems in old age, to see very constrained in what they can do or expect. But we're looking more and more about their positive contributions that they can continue in their families, in their communities. We increasingly have models where older people also care for each other, and there are various ways on how public policy can create incentives and support that this happens. And versus then the intrinsic capacity is all the health, physical and mental capacities. As I said, we have had an earlier strategy and action plan for Europe since 2012, and we are now at a stage where we are looking how the uptake has been in the last 5 years with countries. And again, here very similar main strategic areas than the global action plan. But what is specific for the European action plan is that we have discussed with member states very concrete priority interventions and some supporting ones. So you see here we have a focus on 8 interventions, and I will mention some of them in their relation to frailty. In fact, most of them can have some interplay and effect with prevention. Certainly falls is one of the, can be an important trigger of frailty. The lack of physical activity, or positively physical activity basically for all people, including those living with frailty, has shown positive effects, and I understand this is also one of the package that will be discussed under this work package that for which Slovenia is responsible. Vaccination, control of infections in various settings. It's still a large public health gap in many countries. Then quality of long-term care is very much has to do how we better address the needs of older people, many of them frail. Basic home care support, and very important to have a geriatric and gerontological staff capacity. And this means not only that there are some highly trained geriatricians that can work in teams, for example, in a hospital setting to do comprehensive geriatric assessments, but it means that basically every health and social care staff who is working with or for older people would recognize the main symptoms of frailty. And of course, they have to do this by having an adequate training, so it needs to be basically included in all of their curriculum. We cannot have a geriatrician looking over their shoulders, standing behind them. Increasingly, this is a policy that countries try to aim for, so to have a possibility almost by all entry points into health and social system where older people present themselves, to be able to see that there might be underlying complex syndrome that should be addressed, and then to see who could address this, and very importantly to make sure that this frailty syndrome is not getting worse by often very successfully treating, let's say, some acute conditions, but in fact worsening considerably some underlying, or not underlying, but maybe at the same time existing frailty conditions of older people. And specifically, this also is important for people with mental capacity declines. In a sense, all the healthcare settings need to ask themselves, are we health-promoting settings for people that live with frailty? So are we able to identify their nutrition needs, even make sure they have the kind of physical activation, that are not developing pressure ulcer and so forth. So this is certainly one of the important components. I understand that is also what the joint action is looking into. Now, as I said, there are many ideas on and actually things that are implemented in policies, but we do not have a complete picture on the evidence and the reviews that would, from the literature, from the research, support to the same level all of the interventions that are currently tried. And one major project to look into that had been here at headquarters, the so-called integrated care for older people guidelines, which did also extensively the literature reviews, but then also consultations and delphis with experts to come up with a number of recommendations where the evidence could be ranked and rated, and so to say, how strong is the recommendation, how strong is the evidence, and that's something really way we are going to in the future. And so not surprisingly, where evidence was strongest from research is physical activity, force prevention, malnutrition, and specific support of family care like training. Now, we will have a survey with member states, very much also linked to reviewing the now half-time of the global action plan. But already now we have quite a rich overview on experiences from other sources, and one source that we have worked on for the purposes also for this the paper we have submitted for the conference is to look on the policy review that countries have done for the United Nations Economic Commission for Europe. Has a very important role on aging policies and does every 5 years a review of the Madrid International Plan of Action and Aging, and also it has usually much broader scope than looking only at the health dimension. It has some good entry point to look into what has been done in the aging field specifically, and there are actually 42 progress reports available from the 53 countries for Europe, and also very promising. We see that we have over the last 5 years or so almost more than 20 national strategy and action plans. We haven't in detail analyzed all of these. They would certainly come up with additional information and maybe even a more comprehensive coverage of what is done. Now, what we have seen is a majority of countries is addressing all 5 areas where we split health and long-term care in 2. Very interesting, in fact, how many countries address systematically long-term care now, and also the growing awareness about the importance of supportive environments, much of which is action on local government level. And then we also see quite a good uptake on some of the specific interventions that I have mentioned. And part of this implementation is very innovative models. Just to give, because there's not that much time right now to discuss this, but just to give an example, one idea is to, when it comes to trying to keep people, enable people to live as long as possible in the community with not have functional limitations. that before starting offering a big package of comprehensive home care, to actually start with a phase of, let's say, 3 or 4 weeks of very intensive assessments and training of the older people. For example, if somebody comes with after a stroke or after a fall and has gone through the initial rehabilitation, but then that there is that the home care service first sees together with health services what can we re-enable the person to do, which means, for example, to which extent can the person relearn, for example, to do the cooking themselves. And so other new innovations is the increasing involvement of voluntary sectors, and also to more and more mobilize what older people can do for themselves. And one trend is a positive trend. We have a declining gap in life expectancy in some countries, which means more older couples live together and can provide a lot of support to themselves, including involving more and more men in this. And public support can be very effective in helping make this happen. I will skip here a bit the specific review that we did on nutrition. We've seen there's quite a number of countries that have specific measures on nutrition, and something I have put on the table here is the whole field of what can age-friendly environments, what can a local policy contribute. And we have, together with, in a joint project with the European Commission, come up with a set of publications on that. And these publications also give you a number of very concrete examples on local level where often a lot of the support to people with frailties are. And then you can start also looking into your environment. You'll discover when on my way to the airport, I try to open my computer and sit on this bench. It's not possible. You will glide down from this bench. This is a country that otherwise has made a lot of progress with pro-aging, age-friendly policies, but there are still some designers and architects that put their modern design over age-friendly design, and here I just couldn't sit there and open a computer. There are other examples around the world. We talk about the benches that should be adapted to older people, but on the other hand, maybe you don't want to have these benches because you don't want to have somebody sleeping in the could then be sleeping in the park, and then you build benches like that where nobody will sit for long, and probably older people will not even try. Or you can also try to make sure no homeless people sleep in the entrance, and then you put these spikes, or you put it under the bridge. And I don't want to know what happens if a person with even mild dementia is not seeing these. So something I will not have the time here, but what I would very much look forward is the discussions that you also have on how to introduce technology. I think that's a very big field, and one where systematic approaches are still sometimes lacking, and here also we have this in a chapter in one of our publications. So this was more I understand some of this was more an appetizer, and it needs much more in-depth discussions, and I look very much forward to this conference contributing to that. But I think the main message is here that we have now a very strong growing evidence base, also from practice examples, and overall a really promising uptake and commitment of member states to work in this policy field. Thank you very much.